In our discussion with weapons on terror. So weapons on terror, they can be biological, chemical, and radiologic events. It's not every day that we have an event or an explosion that can spread dangerous material. So as we talked before, that it is essential for healthcare workers in our community to have drills, so disaster drills, to be able to be prepared for any type of potential disaster, especially with these weapons of terror. A blast may be a result of terrorism. It could also be, so when we look at blasts, we look at blast injuries. It doesn't always have to be something of terrorism. In our area too, we could have explosions with, people who are welding, for example. So there's welding accidents that we can have blast injuries with. There's also explosive devices, pipe bombs, fertilizer bombs, dirty bombs, those kinds of things can, lead to blast injuries. When triaging a patient involved in a bombing, we need to have a heightened awareness that serious internal injuries from the blast waves may not be immediately evident. So we have to look for the potential injury that occurred because of that blast wave. So we know that blast waves affect patients through injuries with shrapnel, rupturing of their organs, because of those pressure waves. So they can have abdominal or head injuries. Victims are thrown because of blast injuries. They can have head injuries. So when we look at blast lung, those blast waves, they pass through that air-filled lung. It results in hemorrhage and tearing of the lung. So they have problems with ventilation perfusion mismatch, and possibly they could have also an air emboli. Some signs and symptoms you might see: dyspnea, hypoxia, tachypnea, or apnea. So all the respiratory, we've got the ventilation perfusion mismatch. So we're going to have some signs from that. Tympanic membrane rupture from the blast wave as well. Things you might see in your patient is hearing loss or tinnitus, so ringing in the ears, having pain or dizziness, or otorrhea, which is the drainage that comes from the ears. Abdominal and head injuries. We can have abdominal hemorrhage. And with that abdominal hemorrhage comes pain, guarding, rebound tenderness. Could also see rectal bleeding, and then nausea and vomiting, and then head injuries, which you've had that information previously. So signs and symptoms of head injuries. Biological weapons are a way to spread disease among the general population or the military. It can be covertly, which means it's not obvious. So covert method of affecting the target, they can contaminate food and water, and therefore affect a small target area, or they can go as large as globally. So it could be a vector, which can be an insect or an animal or a person. So it's not obvious, but it can be spread through those methods. Biological weapons are easily obtained and easily disseminated. It can result in significant morbidity and mortality rates. It can spread through inhalation of vapors, or it can be within direct contact. They can also spread globally because of travel. So increase in travel, we can move from one area to the next pretty rapidly. So an appropriate management of a biological threat includes rapid recognition of the potential weapon, use of the proper personal protective equipment, decontamination, isolation or quarantine of the infected, and then administration of the appropriate antidotes or medications to people that are at risk. So it could be antibiotics, vaccines, things like that. Isolation precautions for biological terrorism. Biological agents may be delivered or spread by a number of ways. So because of the travel I mentioned, it can be spread in different areas. It can be 1,000 miles apart because of the mobility of the people, of course, through travel. Healthcare providers should know the mode of transmission, incubation periods, symptoms, and communicable periods of these diseases. The outline, there is an outline by the CDC. They provide that information, and healthcare workers need to be, aware of those of that outline. Okay, so some of the signs and symptoms are common to, are similar to those common disease processes. So looking at the picture as a whole, and just being a heightened awareness, as we spoke before, about seeing consistencies or trends in the patients that are being seen. Isolation practices depend on the infecting agent. Always use standard precautions. Some agents require transmission-based precautions. And then terminal disinfect and disposal of the waste. Also depends on the infecting agent. So we want to know how to handle the waste, where to handle it, and then also what do we do for our patients? Appropriate decontamination. Biological weapons include any organism or toxin that's found in nature that can be used to kill or injure people. So one category of weapons of mass destruction is, a biological weapon. So they can be a weapon of mass destruction because of the ability to disable or kill a large number of people at one time. Bioterrorism, using microorganisms with deliberate intent to causing infection to achieve military or political goals. So for example, delivering of the anthrax spores that were going through the postal services, as an effective agent after the 9/11 attacks. So they already had the terror of the 9/11 attacks, and then the next scare was the anthrax that was being sent through the mail. So the biological weapon anthrax is a gram-positive rod that lives in the soil in the spore state. Whenever it's in contact with animals or products or inhalation of those spores, it results in infection. It can travel a great distance. It can be aerosolized. It's also odorless and invisible, so it can be released, and it can be miles from the site of that where the infection is. So the release can be miles from the site of infection. Incubation period is 1 to 6 days. There are 3 methods of the infection that include skin contact, GI ingestion, or inhalation. So 3 different ways in which you can come in contact with that biological weapon. Inhalation is the most severe, with a potential incubation up to 60 days. If we have a patient who comes in and we know that they have anthrax, have been exposed to anthrax, we know that they need to have a thorough assessment. a complete thorough assessment, with that respiratory assessment being the top priority. So it begins in stage 1 where they have flu symptoms, and then it follows by recovery. So usually it's a real brief recovery, and then they'll return for treatment of the second stage, which is usually within 1 to 3 days. So the second stage, they have respiratory distress. They may have, during that time, they're going to need some ventilatory support. Antibiotics usually can halt the process of the disease at this point, but it may progress to meningitis with subarachnoid hemorrhage. Death may occur within 24 to 36 hours after the onset of the severe respiratory distress. So the disease is not, it's not contagious. It can't be spread from person to person. There are some strands that have been developed that are resistant to penicillin, so that becomes a problem when we start to treat the patient. We know that the treatment includes penicillin V, erythromycin, gentamicin, doxycycline also. But if there is a mass casualty incident and we know that that has been spread, they can also do a prophylactic treatment for exposure. So antibiotic treatment begins, if it begins within 24 hours after the exposure, then death can be prevented. So ciprofloxacin or doxycycline for 60 days, prophylactic after an exposure is recommended. So they're easy to get access to, as well as inexpensive meds in those cases for mass casualty incident. Smallpox is also a biological weapon. So the incubation period for smallpox is 12 days. It is contagious. It's spread by direct contact and contact with clothing or linens, or by droplets from person to person. Something to remember, though, is smallpox is only contagious after the appearance of the rash. So patients will have, it will manifest by having a high fever, malaise, headache, backache, prostration, which is that extreme physical weakness or the emotional exhaustion. And then they will have those maculopapule rash that appears on the face. And those are those flat and raised skin lesions is what you're looking for. It also occurs on the mouth and the forearms after 1 to 2 days. And then after that is when it progresses to the trunk. So it has a progressive order that it follows. And once once it reaches the trunk too, it also can become vesicular to a pustular type lesion. Treatment is supportive with antibiotics for any additional infection. Also making sure that we maintain isolation using transmission-based precautions. So we use standard precautions, we use contact, and we also use airborne precautions. So they should be in an AIIR room, which is your airborne infection isolation room. That is your negative pressure air rooms. Laundry should be autoclaved prior to washing with hot water and bleach. And then making sure that we have appropriate disposal of the biological waste. We also vaccinate all that are exposed within 4 days. That helps decrease the risk for death. Picture of what it looks like in comparison to chickenpox is you have smallpox versus chickenpox, and how it actually progresses. So chemical weapons The effects are more apparent and occur more quickly than those that are biological weapons. Chemical weapons are generally defined as devices that use any of one of the number of chemical mixes in such a way that's going to inflict death or harm to human beings. So it's also known as weapons of mass destruction. And when we look at the different major groups of chemical weapons, they are dispensed in different ways. So they're dispensed through aerosols, liquids, or vapors that enter the body through the eyes, the lungs, or the skin. And when we look at those agents, they also have different components that are that vary. Volatility is one of those, the tendency for a chemical to become a vapor. It includes a physogene and cyanide. Most are heavier than air, so it is recommended that people stand up versus lay down. So those, being on the ground is where it's going to be heaviest, and therefore they're going to have the heaviest exposure when they're at a, at a lower level. So standing up is better for that type. So the volatility, persistence, chemical is less likely to vaporize and disperse. So it's more likely to penetrate and cause secondary exposure. So the persistence. And then toxicity, it's a potential of an agent to cause injury or harm to the body. And latency, the time from absorption to the appearance of symptoms. The last thing we look at is limitation of exposure. That is essential with the evacuation and decontamination to do that as soon as possible and as close to the scene of the incident as possible. Types of chemical agents. We've got vesicants, nerve agents, blood agents, and pulmonary agents. We're going to talk about each of those. So vesicants are chemicals that, are blistering agents. So they include things like lewisite, sulfur mustard, nitrogen mustard. The physogene is also one of those. So those vesicants are the chemicals that cause blistering and burning, and it also results in conjunctivitis, bronchitis, pneumonia, death. So any exposure to skin, those areas that are exposed to the chemicals, burn and blister. Respiratory effects, they can be serious and can cause death. There is an oily substance which penetrates the skin, so decontamination is important using soap and water. We do not scrub or use a hypochlorite solution, and that's simply so we can, we don't want to increase the penetration of that chemical. If the eyes are exposed, we need copious amounts of irrigation, and we have treatment. The treatment that we use for the lewisite exposure is dimercaprol, which is IV, or topical, which is an anti-lewisite medication. Vesicants were used in World War I. It was also used in the Iran-Iraq conflict in 1980 to 1988. These vesicants were used to disable opponents. So mainly it was to incapacitate people. So there was minimal deaths. It was like less than 5%. However, there was a large number of injuries. And with mustard gas, for example, it was very painful recovery with the need for multiple skin grafts. So we know with multiple skin grafts, and you've got these skin burns, that one of our major serious complications was infection. So no, they didn't die. There was a low minimal death to it. However, the burns it was very painful. Painful recovery, you know. Ugh. Nerve agents, the most toxic agent in existence are the nerve agents. Okay, so they are nerve agents like sarin, soman, taban, and organophosphates and VX. So those are both of the organophosphates and the VX are actually pesticides. So unfortunately, you know, these are inexpensive. They're effective in small quantities and they're easily dispersed. They are liquid. They can come in liquid forms. They can evaporate into a colorless, odorless vapor. So they can be inhaled or absorbed percutaneously. So the way it works is we know that acetylcholinesterase inhibitors are also called cholinesterase inhibitors. They inhibit the enzyme acetylcholinesterase, and that breaks down, inhibits the enzyme acetylcholinesterase from breaking down acetylcholine. So essentially, you have acetylcholine that is not dispersed, it's not removed, it's not broken down. So we have an increase in acetylcholine, and that leads to the cholinergic crisis or the cholinergic effects. So essentially, you have continuous stimulation of the nerve endings. Those cholinergic symptoms that I'm speaking of are like the bilateral miosis, which is your excessive constriction of the pupils of the eye. They have visual disturbances, increased GI motility, nausea, vomiting, diarrhea. So if it's ingested by GI symptoms, they're going to have the GI symptoms first. If it's inhalation, then they're going to have the respiratory symptoms first. So these symptoms can then progress, you know, even further. And you know that there is a lethal dose if it's causing the person to have a loss of consciousness, seizures, copious secretions, apnea, and of course, death. So how do we treat? We treat with supportive care. Atropine is, we follow the protocol it follows when you give the atropine and what is it used for. It helps to clear up those signs of anticholinergic activity. We look for, has that returned? So we're following the protocol of atropine until that they're clear of those signs of the anticholinergic activity. So do they have decrease in the secretions? Do they have decrease in the GI motility? So there is a protocol that they use with the atropine to stabilize the patient. They also look at using the antidotes. So prolidexine is an antidote for nerve agents. It also will give benzodiazepines as well. So benzodiazepines are used to control the seizures and alleviate apprehension and agitation. So hope you understand that came out. The other important part is to make sure that we contaminate. Copious amounts of soap and water, saline at least 20 minutes. We do not wipe off. Again, we're trying not to cause it to absorb further. And we know that plastic equipment will absorb sarin gas. So we have to remember that as we take care of our patients. So decontamination, extremely important. Blood agents, you've got hydrogen cyanide and also cyanogen chloride are two types of blood agents. They directly affect the cellular metabolism. It results in asphyxiation through that alteration in the hemoglobin. It can be inhaled, ingested, and or absorbed in the skin and the mucous membranes. It's going to lead to respiratory muscle failure, respiratory arrest, cardiac arrest, and death. And the treatment really is supportive and also to give the antidotes. So amyl nitrate needs to be given after the patient's placed on, after they're intubated and after they're on a ventilator. You want to rapidly administer the amyl nitrate, the sodium nitrate, which is an antidote for cyanide poisoning, the sodium thiosulfate, which is also used for cyanide poisoning. Pulmonary agents, physogene and chlorine, they are both vaporized rapidly, causing pulmonary injury. Physogene is the most dangerous. In high concentrations, it's a painful and agonizing death and can occur within hours. If it's a lower concentration, death usually occurs within 12 to 24 hours. So there's no specific antidote or treatment. So what it actually does is it destroys the pulmonary membrane that separates the alveolus from the capillary bed. It's going to disrupt that alveolar capillary oxygen transport mechanism, and the capillary leakage results in fluid-filled alveoli. So the patient's going to have pulmonary edema. They're going to have shortness of breath, especially during exertion. And it'll begin with initial hacking cough, and then it's going to follow by that frothy sputum production. So respiratory support by ventilation, as well as osmotic diuretics to help decrease the fluid in the lungs. Radiation exposure may occur because of nuclear weapons, nuclear reactor incidents, or exposure to radioactive samples. So with radiation, the exposure to radiation is affected by the time, the distance, and the shielding. So they always note those three things. Those are the precautions that we always take, even when we're in, X-ray. So the rad techs always take those precautions as well. So there's three types of radiation-induced injury that can occur. You've got the external irradiation contamination with radioactive materials and incorporation of the radioactive material into the body, the cells, the tissues, the organs. So external radiation, it occurs when all of the body parts of or part of the body is exposed to radiation. It's going to penetrate or pass through completely through the body. So in this type of exposure, the person's not radioactive and it does not require special isolation or decontamination measures. Irradiation does not necessarily constitute a medical emergency. Contamination, the exposure to the radioactive gases, liquids, or solids that require immediate medical management to prevent incorporation, which incorporation means that there was an actual uptake of that radioactive material into the cells, tissue, and susceptible organs. So the organs that are most susceptible or can be involved are the kidneys, the bone, the liver, and the thyroid. Radiation decontamination. So hospitals and community disaster plans, they should be in effect whenever we're managing a radiation disaster. Access restriction is essential to prevent contamination of the actual facility. So that's the one of the most effective ways to protect the hospital itself. So preventing contamination of the hospital itself is to use triage outside of the hospital. So we also want to make sure that we cover the floors, use strict isolation precautions to prevent tracking any of the contaminants. Other ways to protect the facility is the air ducts and the vents are sealed. Waste is double bagged and labeled as radiation waste. And then protecting our staff. So wearing resistant gowns, 2 pair of gloves, caps, goggles, masks, and booties. And then using dosimeters, dosimeters device. So using a radiation survey meter, that's the very first thing you're going to do. So a patient comes to the emergency department. First thing we want to know is how much radiation have they been exposed to. So using a radiation survey meter, that is the first intervention. So the patients following that would then be directed to the decontamination area. They decontaminate each of the patients outside of the emergency room with a shower. They have a collection pool, tarp, and the collection containers for the patient's belongings. They also have their soap and towels and disposable paper gowns for the patients. And that runoff from those showers has to be contained. Okay, so following the decontamination, we want to make sure, like I say, having all of the gowns contained, everything is contained in a container. But then after they are decontaminated, then the patient's resurveyed. So we want to go back to that radiation survey meter again and survey that and see where the patient stands. So do we get them to a level that is acceptable, or do we need to reshower that patient? Okay. So we always keep in mind too, not to have, contamination. So we perform the showering again so that we don't contaminate clean areas from the runoff from the showering. We look at biological samples, nose and throat swabs, and the blood also. Internal contamination requires additional treatment. Catharsis, so purification of the, talking about their emotions, and then also gastric lavage and chelating agents. So gastric lavage, where we irrigate the gastric, basically pumping the stomach is one, and then chelating agents, which helps with the removal of heavy metals. Acute radiation syndrome. Radiations, it's also known as radiation sickness or radiation poisoning. Acute radiation syndrome is it's dose rather than the source of the radiation that determines if they're going to get the acute radiation syndrome. So we know that all body systems are affected by the acute radiation syndrome. However, those cells that rapidly reproduce are most commonly affected. So the hematopoietic system, the GI system. When presenting signs and symptoms, it does help us determine the predictability for survival. So probable survival, the patient has no initial symptoms or only minimal symptoms. So they may have nausea and vomiting, and those resolve within a few hours. Somebody with a possible survival status is they can present for nausea and vomiting, and it's going to persist longer, so 24 to 48 hours. So possible survivors. And then improbable survivals are acutely ill with nausea, vomiting, bloody diarrhea, and shock. At any point you see that there are neurological symptoms, it does suggest that there has been a lethal dose. So some sample questions here, just based on disaster nursing. Just have 3, just to give you some idea here. And to just test yourself. This kind of content leads itself to, there's a lot of detail. So we have to test ourselves based on some scenarios. So in the last discussion forum, you should know that the patient with a Glasgow Coma Scale of 5 was in the category of Black, for example. So testing yourself that way helps. So I have like 3 questions here just to give you some samples. I already discussed with you the exam in regards to the first portion. There are a lot of facts that you'll want to pay attention to and know who had a part in some of the major health reforms. For example, Medicare, Medicaid, who had a hand in that? So that's one example. So here's some examples of some questions for disaster nursing, and I have the answers to follow. So is the following statement true or false? Healthcare facilities are required by the Joint Commission to create a plan for preparedness and practice this plan once a year. Is it true or false? False. The key there was twice a year. So the Joint Commission, you do have to have a plan. So the Joint Commission, they want all hospitals to have an emergency preparedness plan, but it has to be practiced twice per year versus once. What is the name for the triage category in which injuries are significant and require medical care, but can wait hours without threat to life or limb? Delayed, expectant, immediate, or minimal? Correct answer is delayed. Delayed injuries are significant and require medical care, but can wait hours without threat to life or limb. Expectant injuries are extensive and chance of survival are unlikely, even with definitive care. Immediate injuries are life-threatening but survivable with minimal intervention, and minimal injuries are minor, and treatment can be delayed for hours to days. And the third and final question, what is level A protection or protective equipment? Is it A, self-contained breathing apparatus and vapor-tight chemical-resistant suit, gloves, and boots? Is it B, high level of respiratory protection, but lesser skin and eye protection, chemical-resistant suit? Is it C, air-purified respirator, coveralls with splash hood, chemical-resistant glove and boots, or is it D, the typical work uniform? So what level protection equipment? A, it's the self-contained breathing apparatus and vapor-tight chemical-resistant suit and boots. If you look at the previous question, they really didn't change the order in which the information was shared. So your top level A was level A, B was level B, C was level C, and then level D. So it was in order in which the previous, so A, B, C, and D, they didn't switch it around, which is good. Now you can have that in your mind as to what is particular to each type of protective equipment. Okay, that wraps up disaster nursing. Discussion forum will be due this week. I'll put the details in the announcement.